Hello, family. This is Josh, your brother slash son, if this is dad watching this. Okay, so what we're going to go over today, because my test is in like 6 hours, well, 5 hours, 5.5 hours, whatever. What we're going to go over today, and what my test is mainly going to be over, is the spinal tracts, which we've already gone over, and the associated nerves that are supplying those, or that the tracts are supplying. Also, stroke presentations. So how someone suffering from a stroke will present themselves when they come to my clinic, and I have to make sure, they've already been diagnosed with a stroke. The reason that I need to know this stuff is so that when I'm working with them, I understand their strengths and their limitations. But in this class specifically, neuroscience, they want us to be able to identify what sort of cerebral artery has been infarct, or an embolism has happened and basically blood has came out and it's killed that portion of the brain. And so there's specific symptoms that will take place that will allow me on this test to identify what cerebral artery and what lobe and what specific area has been affected. And again, this is something just like the spinal tracts I've spent probably 20 hours on at least this week. Not today, obviously, because today just started. But anyways, let's get this thing going. All right, so the first thing we're going to talk about is the left MCA superior division infarct. Now, with that specific infarct, you're going to see right face and arm weakness. UMN means upper motor neuron. So with upper motor neuron deficits, you're going to see a lot of proximal strength, proximal weakness. So like shoulder, torso, stuff like that are not going to be as strong as, say, like your elbow, wrist, forearm. So in that area as well, on the left side of your brain, where the middle cerebral artery, that's what MCA stands for, comes up, we're looking at the motor cortex is that whole front side there. So you're going to have some motor deficiencies. That's where the face and arm weakness come from. There could also be some right face and arm cortical type sensory loss. So like touch, feel, pain, all that could be associated with it. But the biggest indicator of a left MCA superior division infarct is Broca's aphasia. Goes back into the fact that their motor cortex is affected. Broca's aphasia means that they know words and they know what they want to say, but they don't have the ability to say it because their mouth just doesn't work. Slurred speech and stuff like that. All right, moving on. Left MCA inferior division infarct. Now this one, so the superior division comes up on the brain on the left side. The inferior division goes down on the brain. And in that area, we have what's called our temporal lobe. Our temporal lobe has Wernicke's area. So this individual can probably move their mouth and they don't have any issues speaking, but it's all gibberish. It's incoherent. You can't understand them. That's Wernicke's aphasia. Now, because the temporal lobe is affected, their right visual field is going to have a deficit. They're not going to be able to see in their right visual field. Obviously, since it's the left side of the brain, the right side is affected. So motor absence or weakness, known as hemiparesis or hemiplegia, that can be present. Even though it's in the temporal lobe and the motor cortex is up here, the infarct can cause motor absence or weakness. And the patient, because in the temporal lobe, that's where our association cortex is as well, the patient may seem loopy or confused. And there may also be some right face and arm cortical type sensory loss, so the ability to feel sensations and stuff. Moving over to the left MCA deep territory infarct. Now this is the middle cerebral artery that's inside of your brain. We know this as what's called the internal capsule. So if I'm holding a brain, on the inside portion, on the left side, you have what's called your internal capsule. Your deep MCA veins feed that. So if there's an infarct there, there's a dysfunction there. And the biggest indicator is what's called a pure motor hemiparesis, pure motor weakness on the right side of the upper motor neuron type. So we're going to see, and again with upper motor neuron type, proximal movement and stuff are going to be affected. So what's closest to the body will be affected. With upper motor neuron deficits, you're also going to see increased reflexes and increased tone. What that means is they may have, if you can think of increased tone and increased reflexes, like they move just sporadically, like the reflexes are almost exaggerated, but as far as actual movement, it's not there. And this is done with the little reflex hammer. And the larger infarcts may display aphasia. So because it's on the left side, and because it's the deeper part of the brain, you may see Broca's aphasia or Wernicke's aphasia, because those deep veins will feed both the lateral portion of the frontal lobe and the lateral temporal lobe there, where Broca's and Wernicke's area are both located. So it's potentially something you can see, but the biggest indicator is that pure motor hemiparesis. All right, moving down to the left MCA stem infarct. Now stem refers to the brain stem. And if you can imagine, if there's a deficit at your brain stem, those arteries are fed up, they come from the heart. Basically the whole left side is going to be affected. That means the lateral frontal lobe, lateral temporal lobe, a little bit of the occipital lobe. So what that's going to entail is basically all of these things and then some. So like Broca's aphasia is fair game, Wernicke's aphasia is fair game. But more importantly, we have this aphasia called global aphasia, which affects both. Now because sight is in the temporal lobe, or there are some tracks there for sight, you're going to see what's called homonymous hemianopia, which means that the same visual field, the right visual field on both eyes, are going to be affected. That's what homonymous hemianopia means. Now the right visual field would be the right side of my hand right now. Both of my eyes, if I had this, I wouldn't be able to see my fingers right here. It would be invisible for the most part for that right side, or the right visual field of both my eyes, which means that the left radiation receptors in my eyes, both superior and inferior, are being affected. And then another indication is a left gaze preference. And the reason there's a left gaze preference, even though the left side is affected, you think, well, wouldn't that affect the right side? Not when it comes to the motor muscles of the eye. Because that right side is affected, my ability to move my eye this way is lost. So my gaze stays to the left, if that makes sense. All right, moving on to the right MCA superior division infarct. So this is your right side MCA superior division. So the right lateral frontal lobe is going to be affected. So just like with the superior division, well, similarly to the superior division of the left MCA, the right MCA, you're going to see left face and arm weakness of the upper motor neuron type. And you're going to see left hemi-neglect. Hemi-neglect means that everything on my left side, I'm going to neglect. Now, not necessarily motor neglect, but physical objects. I just will neglect to see them because of this hemi-neglect that I'm experiencing from my infarct. And you may also have some left face and arm cortical type sensory loss, which means that I won't be able to feel touch and pain. I potentially won't feel these things if the infarct is large enough. Moving on to the right MCA inferior division infarct. Now this is the lower portion of the MCA going down to that right-sided temporal lobe, which we talked about a second ago, affects vision. On the right side, we don't have Broca's aphasia, or Broca's area or Wernicke's area. So you won't see any aphasia, but you will see a profound left hemi-neglect. That's a big indicator. You will also see left visual field neglect, or I'm sorry, deficit. So their left visual field will be affected. Sometimes not in both eyes, it may just be the one eye. Because on your left side of your brain will affect the left eye, and the right side of the brain affects the right eye. Somatosensory deficits also present, mild left side weakness. Well, you could actually see a lot of weakness. That's not very becoming of most of the cases that we've been presented for right MCA inferior division infarct. But the biggest indicator is a profound left hemineglect and a right-sided gaze preference. So that's the difference when it comes to right-sided MCA inferior division infarct and left MCA inferior division infarct. All right, moving over to right MCA deep territory infarct. Going back to that internal capsule, but this time on the right side. With the deep territory, whether it's left or right side, you're going to see a pure motor hemiparesis of the upper motor neuron type. However, because it's the right side, now you're going to see that pure motor hemiparesis on the left side. Also, the larger infarcts may cause cortical deficits like left hemineglect. So that's the biggest indicator is going to be the pure motor hemiparesis. Right MCA stem infarct. Again, going back up to the stem infarct that we've seen on the left side. For the right side, it's the same song and dance for the most part. You're going to see that homonymous hemianopia, which means that the same visual field, that left visual field, is going to be affected with both eyes, not just one. Also, you're going to see pure motor hemiparesis with cortical deficits like hemineglect, left hemiplegia, which is left paralysis, hemianesthesia. I don't know if I talked about that up here, but hemianesthesia is when you can't feel anything on your left side. So it's like having anesthesia on your left side. And often there's a right gaze preference. So anytime the right side is affected, you're definitely going to see that gaze preference, but specifically with the stem infarct, because you're going to see left gaze preference for the left stem infarct and right gaze preference for the right stem infarct. Left ACA infarct, well, that is your anterior cerebral artery infarct. That artery supplies blood to the frontal lobe specifically, and a little bit of the parietal lobe. So your frontal lobe deals a lot with behavior. You've got motor function in your frontal lobe, like we talked about earlier with Broca's aphasia and stuff like that. But the biggest one for this is the grasp reflex and the frontal lobe abnormalities, behavioral abnormalities. So when you see those coupled with transcortical aphasia, which transcortical aphasia means they are not understanding what you're saying, they can't speak coherent language, and also they're slurring their words of what they're trying to say, but they're able to repeat words back to you. So if they have speaking deficits, but they can repeat words, that's what's called transcortical aphasia, and that is synonymous with left anterior cerebral artery infarct. Also, right lower extremity weakness of the upper motor neuron type, right lower extremity cortical type sensory loss, so not being able to feel anything, and then the larger infarcts can actually cause paralysis on the right side. Moving down, almost done, to the right anterior cerebral artery infarct. Now, on the right side, you're going to see a lot of similarities as the left side, except there may not be any aphasia. Actually, there won't be any aphasia, because on the left side, that's where we have Broca's area, Wernicke's area, stuff like that. So it makes sense that transcortical aphasia would be on the left side. But for the right side, you won't see that. You'll actually only see left lower extremity weakness, left lower extremity cortical type sensory loss. You'll still see that grasp reflex and frontal lobe abnormalities for the left side, and definitely some left hemineglect. If the right-sided arteries are affected, 9 times out of 10, there's going to be left hemi neglect. So they're just going to neglect physical objects as well as their own body on the left side. Larger infarcts can cause paralysis, which is hemiplegia. So I didn't say this before, I need to say it now. If the anterior cerebral artery is affected, whether it's right or left, it's going to specifically target the lower extremities. So the anterior cerebral artery is notable for supplying blood to the parts of the brain that deal with the lower extremities, your legs. Moving over to the left posterior cerebral artery. That artery is going to supply basically the underside of the brain, starting with the temporal lobe. So the bottom part of the temporal lobe and all of the occipital lobe, which means that in the occipital lobe, that is where your primary and secondary visual cortex is. So their vision's gone. That's why the right homonymous hemianopia is happening. Now, it's not total vision loss because it's only the left PCA. So the right visual field is affected. But because it's on the left side, we're going to see some association deficiencies like Broca's aphasia, Wernicke's aphasia, stuff like that, except with a posterior cerebral artery, there's a specific condition called alexia without agraphia. And what that means is the individual may be able to write things. They may be able to write their name or sign stuff, but they can't read. So alexia without agraphia is the ability to write things, but they can't read anything. Larger infarcts can cause aphasia, so even more of an aphasia, possibly at that point transcortical aphasia. Any of the aphasias we've talked about, a larger infarct can cause it. It's rare, but it can happen. Also right hemisensory loss, which not being able to feel stuff, and then hemiparesis. So last one, right PCA infarct, right posterior cerebral artery infarct. You already know enough about these arteries that if it's on the right side, it's affecting the left side of the body. But because it's a posterior cerebral artery, just like this one, we're going to see homonymous hemianopia. Matter of fact, if the patient has homonymous hemianopia or the same visual field affected in both eyes, in this case the left visual field is affected, if you see homonymous hemianopia, it's either going to be a posterior cerebral artery infarct or a stem infarct. Those are the only two types of infarcts that will suggest that sort of deficiency. And then the last thing for right posterior cerebral artery infarcts is the larger infarcts can cause hemisensory loss and hemiparesis. So a little bit of sensation gone and weakness of the left side. And that is clinical symptoms associated with stroke, specifically indicative of the cerebral arteries. Wish me luck on my test.